So I have no conflicts of interest. And in full disclosure, I am not a laparoscopy hater. I actually do lap choles, appies, lysis of adhesions, and splenectomies, which is actually my favorite elective case by far. I'd rather do a lap splenectomy than any other elective case. I love doing them. I do lap ventral hernias, but I hate them. And I quit doing lap inguinal hernias because I was bad at them. So I still don't do them. And I didn't pick my side on this debate. I just got an assignment. So here I am. But clearly, the use of laparoscopy for colorectal emergencies is becoming more and more common. This is a paper published recently, but the data only comes up to about 2009. And it shows that this is in a province in Canada that shows that clearly the use of laparoscopy for colorectal emergencies is steadily increasing. And the interesting thing is actually if you look in this paper, it was more common in the community than it was in academic centers. So in that graph on the right, the solid line is community centers, which are adopting this much more rapidly than academic centers. But both of them are increasing their use of laparoscopy for colorectal emergencies. And I think there's probably two big areas. Most of this is going to be non-malignant disease, right? So most of this is going to be either IBD or diverticulitis. And so I was just going to run through those two real quick. So this is just a systematic review that was done of using emergency laparoscopy for benign and malignant disease. And they broke them out. There was 10 studies in inflammatory bowel disease, 10 in diverticulitis, a couple in malignant disease, which is kind of uncommon. And then obviously colonoscopic perforations are a rare event, but do happen. So, so this is basically a review of those 10 studies that looked at the use of laparoscopy for inflammatory bowel disease. And there was only just a couple of consistent trends. So one was the OR time always took longer when you did the case laparoscopically, which, is par for the course. There was a trend towards quicker return of GI function, but the problem is all these studies kind of define what that was differently. I think we all have a different definition of what return of GI function is. Some of us are happy if they have bowel sounds. Other of us want them to pass gas. Some people are obsessed with patients having bowel movements. I mean, you just have to take your pick. But overall, they seem to get to, return GI function quicker when it was done laparoscopically as opposed to open. And then obviously they had shorter hospital stays because they didn't have all the pain issues. They were able to get up and get around and get moving. So, there's maybe some, mild improvement in some of these things. I think, most of if you start looking at cost stuff, the shorter hospital stays often offset by the increased OR time and the expense. So pretty much here, in conclusion, they said there's, comparatively little data. You really can't, come to any significant conclusions, and there appears at least to be equipoise for this in terms of using laparoscopy for inflammatory bowel disease. Now, really, the poster child for this is laparoscopy for perforated diverticulitis, the Hinchey class 3 cases, and this really was the poster child, supposed to be, the answer and make everybody better. But the question is, what really happened? Well, there have been a number of studies. I haven't quite figured this one out, but all of them come from Scandinavia. So either they're have a lot of diverticulitis in Scandinavia, or they're just better set up to do prospective randomized clinical trials there than we are. But every one of these studies is from Scandinavia. This is probably the biggest and the best one. It came out of Scandinavia, and they had about 100 patients in each arm, and it's probably the largest one. It was published in JAMA, and their primary outcome was sort of a composite score of postoperative complications, and they did use the Clavian-Dindo classification. So these were anything that was greater than a 3A within 90 days of surgery. And you can see the rates were about 31% for complications of laparoscopy, 26% for open surgery. No real difference in mortality rate, and there was a significantly higher reoperation rate in the laparoscopy group, which is kind of a consistent finding in most of these studies. And more importantly, there was 4 sigmoid colon cancers that were missed in the laparoscopy group. So again, if you sort of break this down, no change in complications, no real change in mortality, and there was a significantly higher reoperation rate in the patients that got laparoscopy. And then there were 4 missed cancers in that lavage group. Now, eventually those were found, but the question is always, how much of a delay would there have been? There have been a couple more trials. They all have, cute names. This one's another smaller one, about 40 patients in each arm, and similar findings that there was a higher need for reoperation in the laparoscopy group, but no other major differences. And then again, another one. This one was the Lola study, and about 90 patients altogether were randomly assigned, and they actually had to terminate this study early because the Data Safety Monitoring Board noticed an increased rate of complications in the lavage group. So it's a pretty consistent finding in these studies that there's a higher reoperation rate. But you could argue if you have to go back and intervene, wash them out again a second time, or percutaneously drain them versus giving a patient a colostomy, is that really that bad a outcome? And then finally, the last one was this Delilah trial, and same thing, morbidity, relatively smaller study, not a huge number of patients, but morbidity, mortality the same. They did have shorter time. They actually had shorter time in the OR for this one, and shorter time in the recovery room unit. And I don't know why that was important, like how long they spent in the PACU, but and it did have a shorter hospital stay. Now the other question is, what about the cost of all this, right? So you have slightly higher reoperation rate, but on the other hand, the patients you do open procedure on are almost always going to wind up with a colostomy, right? And then have to have another procedure to take that down. And so these are a couple of studies looking at the cost. And if you look at the whole episode of care over a year, the laparoscopy may be more cost effective, just because a lot of those patients will avoid the issues of having their colostomy taken down or developing ventral hernias from their open procedure. So when you sort of put together that whole episode of care, it may be more cost effective. So when you put them all together, and so you took the biggest 3 studies and did a meta-analysis, and this is kind of where the data comes out. So upper left-hand corner is reoperation at the index admission, and that's clearly favors open surgery. It's more definitive and fewer rates of reoperation during the index admission. When you look at the intra-abdominal abscess rate, again, that clearly favors open surgery. And then if you look at overall, the bottom right-hand corner is 12-month reoperation rate. That actually does favor laparoscopy because, again, if you do open surgery, give the patient a colostomy, by definition, you should have a reoperation within that first 12 months. But then there was no difference in mortality. So my take on all of this is, for laparoscopy, there's no data to support its superiority, right? At best, it's equivalent. In my opinion, is laparoscopy, like anything else, it's a tool, and like any other tool, you have to know when to use it appropriately. So I think you have to do what you think is best in the patient's interest and what you're most comfortable with, and you should never apologize for doing an open procedure. Thank you.